Good afternoon. Please note that to minimize background noise, all phone lines are muted. You will see that there is a chat box at the top or bottom of your screen. If you do not see the chat box, move your cursor around the bottom or top and it will appear. Please enter any comments or questions there as we go. We will start the Q&A using questions in the chat box. Today's educational webinar is brought to you by the American Brain Coalition Program Committee and is featuring speakers from the American Academy of Addiction Psychiatry, an American Brain Coalition member. I will now turn it over to our moderator, Dr. Justine Welsh, who will begin today's webinar.
Thank you for the introduction and good afternoon, everyone. I'm really excited to introduce our speakers for this webinar, who are both addiction psychiatrists from the American Academy of Addiction Psychiatry Public Policy Committee. Dr. Richard Rosenthal is a professor of psychiatry at Icahn School of Medicine at Mount Sinai. Dr. Hilary Connery is an assistant professor in the Division of Alcohol and Drug Abuse at McLean Hospital under the Department of Psychiatry and Harvard Medical School. Today's topic focuses on policy changes that promote accessibility and quality of treatment for patients with substance use disorders. Dr. Rosenthal will be speaking first about the healthcare platform for addiction treatment. We will reserve time following completion of both speakers' presentations for any questions. All right, you're up, Dr. Rosenthal.
Thank you, Justine. Let's see if I can get this to, there we go. So I'm going to talk about a high-level overview of substance use disorder treatment funding resources, and then talk a little bit about the need for evidence-based medical and scientific policy guidance. Then we're going to look at some of the current legislation and some of the proposed legislation and do some comparing and contrasting, and then discuss some current suggested policy changes to promote increased accessibility to quality treatment for people who suffer from substance use disorders. Going back to a time before managed care, when we looked at how substance use disorder treatment was paid for, the burden on the private and public sectors was about 50-50. By 2003, the increased burden was really attributable to the public sector, so that about 3/4 of it was in the public sector. And then with the passage of some of the acts, such as the Parity Act, the belief was that it would drift a little bit back towards the private sector as insurance companies began to support treatment again. However, when we look at the real data, and this is from the Substance Abuse Mental Health Services Administration, from the National Expenditures for Treatment of Mental and Substance Use Disorders, we find that more than half of the treatment, it's about 54%, is public payers. I don't know what just happened. Let me go back. Some reason it went backwards. There we go. About 54% is Medicare, Medicaid, and federal and other state and local paying, and then the rest is attributable to. I'm sorry, it's 64%. It's about about 2/3 is in the public domain, and the rest is private payers, as you can see up here, which is out of pocket, private, and other private insurers. What's important for perspective purposes is understanding of all healthcare spending that was done in 2009, 2014, and projected for 2020. Only 1% of it is expected to go to substance use disorder treatment. And given the high prevalence rates, given what from the literature is shown to be high levels of morbidity and mortality over the lifespan attributable to substance use disorders, it's really out of sync with the public impact of substance use disorders. Substance use treatment spending is likely to slow from recent trends and even lag behind growth in all health spending. And it has moved a bit more into state and local governments, so that in 2009, rather than the all-payer share nationally for substance use disorders of 1%, the state and local government's share was 5.1%. So you see it's disproportionate. Now, the system is basically supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA, as administered block grants to the states that fund public substance abuse treatment in the states, in territories, and the District of Columbia to plan, carry out, and evaluate substance use disorder prevention, treatment, and recovery support services. But the system that those funds go to, although they are licensed within the states under their various single agencies or multiple agencies for substance use disorder prevention and treatment, it's mostly an independent set of substance abuse facilities. And in 2013, there were 14,148 treatment facilities operational, about 55% of which were private nonprofit facilities. About a third were private for-profit facilities, and the rest were state, local, some federal and tribal governmental agencies. Of those agencies, and I'm going to focus down a little further, given the current opioid use disorder epidemic in the United States, strikingly only 9% of the 14,000 facilities have what are known as federally regulated opioid treatment programs. Traditionally, this is methadone maintenance, but more recently, those programs can also sustain treatment with buprenorphine, which is a partial agonist as opposed to the pure agonist methadone, and also long-acting naltrexone, which is known as Vivitrol, which, as you see below, are sort of de minimis in terms of the number of people treated in these programs, whereas 330,000 people in 2013 were being treated within opioid treatment programs. Why am I bringing this up? Because it's really important to understand that even though 9% of programs have opioid treatment programming attached to them, that is the main active treatment for acute treatment of opioid use disorder that has the highest efficacy rates in terms of preventing relapse. Here we look at data from Baltimore, Maryland, 1995 to 2009, and opioid agonist treatment, which is mostly methadone, decreased heroin overdose deaths very clearly. It's a public health solution. Opioid use disorder medication decreases opioid use, opioid-related overdose deaths, associated criminal activity, and infectious disease transmission, while increasing social functioning and retention and treatment. Last year, we just got the data in from the National Center for Health Statistics at CDC. This is quoted in the New York Times on September 2nd. Drug overdoses killed about 64,000 people, a 22% increase over 2015. If this was due to any other cause, people would be marching on Washington, picketing in the streets. Fentanyl deaths doubled in the last year from 10 to 20,000, heroin 15,000, prescription painkillers 14,500, and cocaine and methamphetamine, which were big problems, especially cocaine, big problems in the 1980s, but then sort of became more quiescent, have started to raise again. So we've got a major set of epidemics going on that needs to be addressed. The problem being is that effective medications are underutilized. If you look on the left there, in the 48 states, looking at the opioid use disorder rates in the general population, nearly all US states lack sufficient treatment capacity to provide buprenorphine and other medication addiction treatment to all patients with an opioid use disorder. In order to prescribe buprenorphine, you need a federal waiver after training from the Drug Enforcement Agency to get the license to prescribe, and there just simply aren't enough providers licensed at this point to treat all the capacity. Concurrently, when we look at people coming into treatment for a substance use disorder, in this case opioid use disorder, in 2014, the admissions treatment plans for people coming into treatment, only 25% of those also included medication for opioid use disorder. 75% of the substance abuse treatment delivered to people with opioid use disorder coming into treatment in 2014 did not have some form of medication treatment, which I said earlier is the most effective intervention compared to just psychosocial treatment alone. Looking again at facilities offering addiction medications, Any medication, about 54% of those 14,000 substance use disorder treatment settings provide any kind of pharmacotherapy, the bulk of which are medications for non-addiction psychiatric disorders like depression, etc. When we look at specifics for opioid use disorders, you see that only 1/5 of the facilities offer buprenorphine, less for methadone. And 41% of the 14,000 facilities in the United States offering treatment offer no medication services at all. So this is why we need medical scientific guidance for evidence-based policy. Surgeon General Murthy's report in 2016 presented a large body of research which clarified the biological, psychological, and social underpinnings of substance use disorder and described effective prevention, treatment, and recovery support services. Future research is needed to guide the new public health approach to substance use and substance use disorders. So let's look at some of the legislation. The first major legislation that passed after 15 years or so of lobbying was the Mental Health Parity and Addiction Equity Act of 2008, MHPAEA. It addressed the potential discrimination in both mental health and substance use disorder benefits in group health plans and group health insurance coverage for employers that had 50 or more employees. And what it required was that the mental health and substance use disorder financial requirements or treatment limitations for benefits such as visits or number of days of treatment be no more restrictive than it was for medical or surgical benefits, meaning that if you did not restrict visit days for, like, say, diabetes care, you could not similarly do that for depression or for opioid use disorder. And in addition, if the coverage included out-of-network benefits for med-surgical problems, it must also include out-of-network benefits for mental health and substance use disorder, and that the benefits would not be subject to separate cost-sharing requirements or treatment limitations that don't only apply to mental health and substance use disorder. So this was quite a step forward. Part of the problem with it is that it didn't have much in terms of making sure that this was being done properly and accountability of the insurance industry. So now we go to the ACA, the much pilloried Affordable Care Act of 2010. And one of the main advantages of this particular legislation was that it identified 10 essential health benefits that, after much lobbying, included mental health and substance use disorder treatment in individual and small group markets, meaning small groups, meaning businesses of 50 or less employees are now included, and also the exchanges, which provided for an expansion of Medicaid eligibility to low-income adults. It further took the Parity Act to the individual market, and as I said, to smaller groups of 50 employees or less, as well as the Medicaid expansion, reducing the burden of the opioid use disorder and overdose problem. So if you go to the bottom there where the asterisk is, you see that Medicaid expansion is associated with an 18.3% decrease in unmet need for substance use disorder treatment services among low-income adults. So there was a measurable impact of the ACA in terms of providing expanded benefit that provided expanded treatment that was going unmet in the population in 2015. In addition, it also added something new called the medical loss ratio provision, which the medical loss ratio is really the percentage of your premium that goes to non-medical administrative or salary support. And what was happening in the past with the advent of managed care is that sometimes 70% of the premium was going to healthcare and healthcare-related quality improvement, and 30% off the top was going to administration, marketing, and executive salaries. And this provision basically curtailed and said that no less than 80% of your premium dollar can be spent on service delivery, essentially. The American Health Care Act, which passed the House, actually, as part of the attempt to get rid of ACA and replace it with something, changed the EHB and retained it for private plans, but without the actuarial value requirement. Translated to English, what that was going to do was increase the cost of mental health and substance use disorder treatments and reducing the benefits to cover it. It also dropped the requirement for states to have Medicaid expansion plans and dropped prenatal care. Similarly, Medicaid expansion reversal and per capita capping of federal spending on services, which alters the financing structure, would have reduced about 30% of substance use disorder medications in terms of coverage, would then therefore reduce access to evidence-based treatment. And the Congressional Budget Office said that 23 million people would be uninsured over 10 years, which obviously would have striking impact in terms of the population needing treatment for substance use disorders. Similarly, the Better Care Reconciliation Act in the Senate, which did not pass, would have allowed states to waive substance use treatment benefits in essential health benefit-based plans. So that kind of defies the whole idea of the essential health benefit in making substance use disorder treatment non-essential. And it would allow them to reinstate underwriting for pre-existing conditions, which would drive up costs, which then similarly would be reducing access to care. The estimate on BICRA would have cut Medicaid funding by $772 billion, which again would have a significant impact on the population, since the public sector and the block grants have the larger burden of addiction treatment in the United States, would have similarly cut back on addiction treatment in the middle of an opioid epidemic. The Medicaid expansion reversal and capping federal health care again would have reduced access to care. You notice that the word affordable in the Affordable Care Act has disappeared in both of these different opportunities to repeal and replace. And the Senate and the House are both, the finance committees are both working on a collaborative plan that will include most of the components of both of these acts in a sort of Hail Mary deal that will have about 90 seconds worth of Senate debate before it is voted on. So stay tuned for that. In 2015, after a great deal of input, including input from the Academy of Addiction Psychiatry, the Comprehensive Addiction and Recovery Act was passed, which gave a comprehensive response to the prescription opioid and heroin epidemics, including prevention, law enforcement strategies, overdose prevention, expanding evidence-based treatments and recovery support. And this is a good thing to support states through the active granting from HHS, from the Office of Narcotic and Drug Control Policy, from the Center for Substance Abuse Treatment at SAMHSA, to expand activities, to develop and expand treatment alternatives to jail, incarceration, to give grants to entities suffering from acute drug crises, where there's been a larger than national arc in terms of increase of overdose deaths or admissions for substance abuse treatment, and to implement community-wide prevention strategies, as well as Attorney General award grants for women offenders with substance use disorders, pregnant or with dependent children. It also puts into place support nationally for prescription monitoring programs, where physicians who are writing for controlled substances, including opioids, are required to check to make sure that patients aren't getting multiple prescriptions for the same controlled substance. Just to put things into perspective again, with and without the impact of the Affordable Care Act, over the time to 2020, SAMHSA Spending estimates that spending overall for mental health and substance use disorders with the continuing Affordable Care Act only adds 2.7% to the bucket. And we'll get back to that a little bit later in terms of what that impact might be. The 21st Century Cures Act had the support of recent Surgeon General Murthy. It formally recognized the national opioid epidemic, by appropriating $500 million in 2017 and again in 2018. So that's $1 billion in grants for state responses to the opioid crisis, as well as funds to NIH and FDA for innovation projects for treatment to accelerate treatment for opioid use disorders, and also supporting addiction treatment and early intervention services for children and adolescents. Remember, primary prevention is really important, and Dr. Connery will talk a little bit about that later. In addition, it beefs up the parity provisions in the Parity Act by requiring compliance with mental health and substance use disorder coverage requirements of the payers, an action plan for enhanced enforcement for mental health and substance use disorder coverage, and a requirement for report on industry investigations regarding parity in mental health and substance use disorder benefits. So it puts some teeth into the Parity Act, as well as what the ACA pushed forward, and also requires the government itself to do a study on the efficacy of parity legislation in mental health and substance use disorder benefits of commercial payers. Recently, President Trump proposed large cuts for the NIH. Instead, lawmakers in both the House and the Senate have joined forces to increase spending on biomedical research. The Senate Appropriations Committee suggested a $2 billion increase. The House suggested a $1.1 billion increase. This is a good thing, and in terms of support of science, which generates a lot of our evidence base, this is really important. In addition, the Appropriations Committees rejected the president's proposal to slash payments to universities for overhead, which would effectively kill university-based research, for example, in the addictions. So this is good. This is a positive thing. So what are some of the suggested policy changes to increase access to quality substance use disorder treatment? Obviously, more evidence-based policy decisions. For example, as I stated before, Medicaid expansion was associated with an 18.3% decrease in unmet need for addiction treatment services among low-income adults. Yet, the SAMHSA spending estimates as an impact of the Affordable Care Act is only 2.7%. And what that tells me is, like other academic studies that have looked at the economics of what's the impact of paying for addiction treatment, paying for substance use disorder treatment, there's an excellent return on investment from $7 to $14 per dollar invested in substance use disorder treatment. The economy actually gains as a result of that. So we need more of this. We need more studies. We need more support from advocacy organizations to promote evidence-based policy and promote the government making use of this in a rational way to help our public that is afflicted with these disorders. And with that, I'm going to hand it over to Dr. Connery to talk about dissemination and the impact of policy change.
Thank you. Next slide, please. So I'm going to talk a little bit about what the current landscape looks like and what we're looking at as far as patient care barriers. Just to reiterate, we know that for opioid use disorder in particular, the medications are highly effective. And whether we're talking about agonist treatment, such as buprenorphine or methadone, or antagonist blocker treatment, such as extended release naltrexone, studies, many randomized controlled studies, no matter how you look at them or slice them, you can see that for all three of these medications, treatment with a medication added to psychosocial services will at least double the probability that a patient will achieve opioid abstinence. And if you look just at agonist treatment, there are many studies suggesting that, in fact, the probability is increased by 5 or 6-fold for good outcomes. So this is really a point of low-hanging fruit, and one where these are medications that take some training to use effectively, but are easily trainable. You don't have to be a specialist to learn how to use these medications effectively. And particularly the office-based medications of buprenorphine and extended-release naltrexone really need to be brought into the mainstream of all prescribers. In support of this, SAMHSA and NIDA have really marketed and advocated in a large way, trying to provide public messaging, online toolkits for prescribers, telephone apps that support prescribers in decision-making and in reference, as well as mentor support through organizations such as the Prescribers Clinical Support System, or PCSS.org, where free mentoring is available to those who are looking to get more in-practice training. Despite all of these efforts, and I think we finally arrived at a place where there's more common agreement on utilizing these medications than there is opposition, we have a lot of patient barriers that stand in the way of healthcare delivery. If we think about opioid treatment programs that deliver methadone maintenance, these treatment programs, number one, don't exist in every state. Number two, frequently have very long wait lists for treatment. Number three, if you live in a state that does not have an opioid treatment program, or you're in a rural area, transportation barriers can be really significant. And since methadone maintenance, while safe and effective, does require intensive monitoring, particularly in the earliest phases of recovery, patients are required to show up for daily observed dosing. And any of these barriers presents a significant burden on those seeking help with methadone maintenance. When we look at the other agonist therapy, office-based buprenorphine treatment, Dr. Rosenthal mentioned that there is a certification process that prescribers undergo. But what we know from studies after physicians are waivered to prescribe buprenorphine is that still a very small percentage of them will actually implement buprenorphine prescribing in their practices. And these barriers are related to time management, reimbursement barriers, the need for more psychosocial support, working in concert with them, and also a sense of not feeling confident that their system in which they practice is sufficient to provide the level of treatment that some of these patients with complex co-occurring mental health disorders and other substance use disorders will present with. So efforts are being made to not only expand the number of prescribers who are waivered to prescribe buprenorphine, but also to put systems into place that will build the confidence as well as allow infrastructure and reimbursement and time needed to adequately treat patients. When we look at antagonist therapy with extended release naltrexone, a historical barrier has been the cost, but also the logistics of setting up a depot injection opportunity, in part because the medication itself is delivered with specialty pharmacies, and there are some logistical hoops that people have to go through in order to do that. It's all doable, but it does require an institutional effort or concentrated for smaller practice effort at building these kinds of structures. And so I think that has been a barrier to broader dissemination with this medication. Medicaid has restricted access despite the increased numbers of Medicaid participants who are in need. I mentioned rural access barriers. Also, many of the substance use disorder treatment centers in the country are they don't have medical personnel attached to them. And that's a huge barrier for being able to access medications that are effective. And then finally, we hope to do better at early detection of adolescent or youth initiation, and the fact that we have a significant proportion of transitional age youth who are rapidly developing opioid use disorder is concerning, but is also not getting the adequate attention as far as medication-assisted treatment. And so, for instance, prescribing for adolescent heroin use disorder has been measured at only 2% actually receiving appropriate treatment, even though treatment has been demonstrated to work in this age group safely and effectively. Next slide, please. When we look at the impact of the Affordable Care Act and buprenorphine access, we do know that it has increased access to buprenorphine waivered physicians within those states adopting ACA, and that there has been increased Medicaid reimbursement of buprenorphine as well as increased spending on buprenorphine. So those are two good outcomes. We have yet to know what the impact is on patient outcomes, and that's being studied now. Next slide, please. Switching over to naloxone rescue of opioid overdose. Naloxone is a rapid-acting antagonist which can rapidly reverse the impact of a toxic dose of opioid. And because it has now been made available in very easy-to-use nasal spray kits, there is a huge push based on the evidence of its effectiveness to really disseminate naloxone rescue kits broadly in the communities. This is not a new idea. Actually, home naloxone rescue kits have been advocated since 1996. And in 2014, the World Health Organization recommended universal access and training to any community person likely to witness opioid overdose. Part of the reason is it's so simple to use, the training is really quite minimal, and there are very, very few, if any, adverse effects associated with its use. And the benefit, of course, is preventing a death. There has been, I think, some public opposition, strong public opposition to the idea that if we provide naloxone broadly in communities, that somehow this is going to encourage opioid use rather than have a good benefit of preventing death from opioid use. This is similar to some of the arguments that have been raised around clean needle exchanges as promoting drug use rather than being a public health prevention measure. There was a recent review done last year by McDonald and Strang looking at all the controlled studies. Mostly were done in heroin using communities, and all of them show support for widespread naloxone dissemination and few adverse effects associated with this. And importantly, there is really no evidence that opioid use increases as a result of broad dissemination of naloxone. Next slide, please. So shifting over to marijuana, this is a very hot topic in many areas because of the expansion of legalization. As of September 14th, there were 29 states and the District of Columbia having laws broadly legalizing at least medical marijuana, and of these 8 states legalizing recreational marijuana, those latter including Alaska, all the West Coast states, Nevada, Colorado, and on the East Coast, Maine and Massachusetts. I would encourage readers who are more interested in some of the details on what we know as far as the documented impact of these changes in legislation on marijuana in the community. Deb Hassan just published in the latest Neuropsychopharmacology a review on this topic. And some of the largest concerns that have been noted include that marijuana supplies are increasingly very high potency, meaning the THC content is much higher than what it used to be with recreational marijuana that was more homegrown. And it's the high potency THC that is most associated with all the adverse outcomes that we see in emergency presentations, including psychosis and autonomic dysregulation. And in spite of the potency going up and becoming so much more dangerous, perceptions of risk of marijuana use have gone down. We believe that this is related to the sweeping legalization and change in laws around access to marijuana. What we know is that when people have low perceptions of risk, with respect to drugs, they tend to use more of that drug. And in contrast, if the risk perception is very high, they tend to use less of that drug. So I think we have a formula that everybody is concerned about, where marijuana in many of its forms is more dangerous than it ever was before, and yet perception of risk is low. We also know that increasingly pregnant women are using marijuana, which is exposing the unborn to marijuana, and we know that there are teratogenic effects of that. And it has also been documented that pediatric exposures, typically accidental, related to edible forms of marijuana, such as cookies and brownies, have gone up in areas where the laws have been implemented. And so obviously these are concerns for public health. Adolescents, in part, again, because of low perception of risk, and also in part because of increasing access or observation of adults using with low perception of risk. Adolescent exposure seems to be increasing, and we have concerns about that because scientific studies looking at adolescents, particularly age 14 and younger, who are using marijuana on a regular basis, have demonstrated both neurocognitive effects of that, as well as changes in brain functioning. We know that adult access has increased with rates of cannabis use disorder going up, and the number of motor vehicle accidents involving cannabis has increased as well. There are some worrisome trends that suggest that those with mental health disorders such as depression, anxiety, post-traumatic disorder are increasingly interested in using legal or medical marijuana to self-treat symptoms rather than seeking professional treatment. And this is worrisome for those of us who are in the mental health field. We have our usual big business concerns about what are the real motives of the industry controlling some of the legal and medical marijuana. The industry is very tightly networked with the tobacco industry and now the e-cigarette industry, and so I think that speaks for itself. And then finally, there have been case reports of individuals having an overdose because they used marijuana that was adulterated by fentanyl, and they were totally unaware of that. So as fentanyl seems to be spreading across the country rather than diminishing, I think this may be a future concern that is really important and immediate. Next slide, please. So finally, looking at nicotine products, but particularly cigarette smoking and tobacco, there is an organization, tobacco21.org, which advocates increasing the legal age of using cigarettes to 21, and all tobacco products, I believe, but cigarettes is the focus. On the next slide, you'll see just a map of those cities and states that have made changes. And if you back up the slide for me, please. This had its origins in early evidence in a study in Needham, Massachusetts, where in 2008 they had phased in 21 as the legal age. And by 2010, they had been able to demonstrate that high school student smoking was reduced in their school systems by 50%, pretty persuasive. So in 2015, the Institute of Medicine and the FDA supported nationwide age 21, predicting that if we changed policy in this direction, that conservatively we could observe a 25% drop in youth smoking initiation, a 12% drop in overall smoking rate, and 16,000 cases of preterm birth and low birth weight averted within the first 5 years of implementing such a policy. And with that, I think we can move to question and answers. Thank you.
Wonderful. Thank you, Dr. Rosenthal and Dr. Connery. Just as a reminder, if anyone has any questions, please write them in your Q&A box located at the bottom of your screen. I do have a question here for either Dr. Rosenthal or Dr. Connery. What are your thoughts on how to balance national policy need with more region-specific needs?
Well, I can answer part of that. I think that, legislation goes a long way. As I mentioned in the 21st Century Cures Act, there's actually language that, not 21st century, the CARA Act, I'm sorry, that ONDCP has grants to entities specifically suffering from drug crises to support implementation of community-wide prevention strategies. So there's an opportunity even within statute, for high-risk localities that are in particular states that are undergoing demonstrable increases in use disorder admissions or overdose deaths for intervention. We know what those areas are. We look at northwestern Ohio, parts of Baltimore, Staten Island, New York, parts of New Hampshire, parts of Massachusetts. There are zones that are identified as hot zones that could benefit from those kinds of interventions. So I don't think it's either or. I think it's both, and I think that smart legislation can address that. But by looking at sort of the national level need, but also then the higher risk need that are in certain localities.
I'll just add to that I think when it comes to mental health and substance use disorder treatment delivery, there are important regional things to pay attention to. One being that regional trends in substances that are being used differ from place to place. Yep. And two being that the infrastructure of what exists to deliver treatment, what's the clinical platform delivery system is very different regionally. For instance, urban areas have concentrated places of healthcare delivery, and that is not generally the case in more rural areas. And then also, of course, there are cultural differences regionally that would greatly impact what patient preferences may be for how they receive their care. So I think there are certain national policy things that are indisputable, such as being able to have access to treatment in the first place, such as being able to access medications that are scientifically proven to improve outcomes from a life-threatening illness. Those to me are the kinds of policy changes that need to be 100% disseminated everywhere.
Yes.
But that regionally, you can have these cultural and trend-driven and infrastructure-driven preferences in the strategy of how you use the money allocated to most effectively reach the people who are in need.
Let me add to that also, to what Dr. Connery just said, that there are also regional differences, as she said, in sort of drug use patterning. And so if we look at the heroin use disorder problem, most of the problem in the West is from black tar heroin, whereas, sort of east of the Mississippi, the problem is mostly powdered heroin, which is sourced differently. The fentanyl overdose problem is mostly in the East right now, because it's usually added to powdered forms of heroin as opposed to being in the Mexican black tar heroin. So obviously communications, although the risk is for everybody to avoid fentanyl if possible, the public service announcements, the educational stuff in communities really needs to target where the problem is mostly showing up. So yeah, there's also there may also be differential impact, but again, as Dr. Connery says, the dollars that are delivered to the states and localities frequently are coming with that opportunity to customize it based on the local complexion, essentially, or character of the problem.
Great, thank you. I do have a question here from an anonymous attendee who writes, my son died of a heroin overdose on September 7th, 2017, which is just incredibly recent. He was duly diagnosed with anxiety, depression, and a substance use disorder. He was 16 months clean, and it appears that they spent $300,000 for treatment. His fourth day of college, he overdosed. I do not want his death to be in vain. We have a big support network that has donated money to us to make a difference. How do I connect with Doctors Rosenthal and Connery? And I did want to read that just because I think it highlights just the devastation and the impact of
Yes.
what the nation is going through in individuals.
Wow.
Well, first, I would say we are deeply sad for your loss, and this tragedy seems to continue without the appropriate level of concern by the general public, as well as those in power of being able to improve this problem, and without an adequate concern for the significant burden of mental health complexity of those who are struggling with opioid and other substance use disorders. And unfortunately, I think that while the overdose epidemic, particularly related to opioids, has gotten a lot of press and a lot of people looking at the problem and talking about the problem, parallel to that, we have a suicide epidemic in this country that is not getting quite the same amount of attention, and there is also a significant overlap in those who are vulnerable to suicidality and those who are vulnerable to substance use. And I'm saying this really to say that there are many losses happening. We need to do more about that, and that treating substance use disorder is very, very important to prevent these losses, and allowing rapid access to treatment is very important to prevent these losses. But we also must be doing the same thing with respect to rapid access to mental health disorders, and when people are becoming symptomatic, to improving our ability to help them be safe through treatment, support, appropriate medical stabilization, and really a change in how the culture is viewing this epidemic and this problem.
Absolutely, Hilary, and I just wanted to comment that the respondent had wrote back. He had also tried to commit suicide 16 months ago, so that resonates there.
Right, and we know that, you know, I mean, everything that Dr. Connery said, I support, and of course I feel for your loss, and none of us are untouched by this, and most of us have, you know, friends and family members that have gone through similar losses, and our patients' families. The issue of comorbid psychiatric disorders, I just want to underscore this as psychiatrists, and, you know, the American Academy of Addiction Psychiatry, and we look at substance use disorders as one of the psychiatric problems that people face. Unfortunately, for the way that the health delivery system has been set up, comorbidity or co-occurring disorders, where someone has a non-substance related psychiatric disorder and a substance use disorder or disorders, is often the rule rather than the exclusion to the rule. And society has not caught up with that. The governments, state, local, and federal, are aware and have made some progress in moving the bar forward in terms of integrated treatment, but it's certainly not mature yet in the system. And certainly our training programs across the board in all medical and healthcare delivery disciplines is not quite optimal yet in terms of educating providers about these co-occurring disorders. And it is a rule of thumb that that the comorbidity or the co-occurring disorders are the rule rather than the exclusion to the rule, and the presence of one disorder almost inevitably impairs the recovery from the other unless everything is treated. So, you know, we clearly understand this. So it's a heavy lift. It's why we speak to advocacy organizations as well as having our own public policy arm at the Academy, because we need to work together to support, you know, better care using the evidence to support judicious policy and legislative decisions, and so that the monies that are spent wisely and help people recover from all of their disorders.
Thank you, Dr. Rosenthal. And if we don't answer any questions during this webinar, please feel free to contact the ABC. You can directly reply through the link that you received for this webinar, and any questions, concerns will be forwarded over to Dr. Connery and Dr. Rosenthal for a reply. I do have a comment here. It says, please comment on how you anticipate the newly introduced Graham-Cassidy might impact availability of SUD treatment.
As I stated, that the Graham-Cassidy is essentially a conglomeration of both the American Health Care Act and the Better Care Reconciliation Act. So it's going to be a mishmash of the Senate non-passed bill and the passed House bill. And my concern is it'll have all of the worst elements of everything. And if it does pass, it will have a dramatically negative impact on all of the issues that we've pointed today that are problematic in terms of access to care. And it will pull dollars out of the treatment system globally. It will reduce the Medicaid expansion. Low-income families will have lower access to treatment, which means that people with substance use disorders in that domain will have less access to care. Medications will become more expensive. Exclusions and pre-existing evaluation will come back into the fold and will differentially impact the cost of care. So in just sort of in every way that you can think of, all of the gains, perhaps except maybe the Parity Act per se, will be unwound. And so I think it's dire. I'm hoping that they are not able to twist enough arms to get it to pass. Like I said, there's going to be 90 seconds of discussion before there's a required vote. The only good news I can think about is I think that there is a limit on the number of days left to actually get this to the floor, at which point it becomes much more difficult for the party in power to readdress it. But it will be a disaster for healthcare in the United States.
Okay, and one final question here. So the higher smoking age of 21 from a health standpoint seems pretty clear, but what about the states with high tobacco income who are more dependent on this revenue? What are your thoughts?
Well, I guess I would say I'm not an economist, and so I don't have particular expertise in knowing how to shift one industry into another industry that has a lot of public health benefit rather than harm. But I know that there are many examples of that having been done. Yep. And I do know also that the food industry is really undergoing a whole revolution in terms of promoting foods that are much healthier and less processed, and all of what we know as health benefits. I think the food industry has been seriously looking at this and developing new products that are better for the American public. And so one thought I have is whether or not an agricultural industry such as growing tobacco or marijuana could not be better shifted into these developments within the food industry.
Like that.
Great. Well, thank you to our speakers, to everyone who joined in today, and especially to the American Brain Coalition for hosting this webinar. As I said, if there are any questions that are left unanswered, please respond to the link that was attached to this webinar today, and we'll get back to you. Thank you so much and have a wonderful day.
Thank you.